So just answering a few questions, Dave's away again with Six Nations, so I'm going to answer some of the questions that have come through for the Q&A. So the first one was about a video for Achilles and knee rehab. Would be awesome if you're taking suggestions. So we'll definitely add that one to the list of videos that we can do. A lot of the rehab exercises that we use, particularly for the Achilles on the mentorship, is we really like to get the patient in a position where they have to really co-contract at the knee. So you got gastroc, you got hamstring, you got quad working under isometric conditions, and then we're loading the Achilles tendon from there. So definitely add that to the list of things that we can maybe add to the public Instagram and stuff. But that's definitely something that we teach a lot of on the mentorship. Obviously then it just depends on the client and what we're trying to actually achieve and where those exercises actually fit into the rehab. So obviously a lot of those probably wouldn't be done early stage, especially we're going to put a lot of load through the Achilles for an actual Achilles tendon case. But that will definitely be end stage before we're getting them doing high level hopping or anything like that, where we definitely want to get that Achilles tendon tolerating quite high loads through it itself. So exercises for shoulder impingement, again, similar to the last one, obviously this is going to vary patient by patient. We're going to have to look at their history, we're going to have to look at their mechanism, we're going to have to look at their assessment, etc. But some of the things that I definitely be considering for shoulder impingement is their upper rib cage involvement. Again, we've got a couple of tests that we're going to check for that, checking overpressure on neck flexion being one of them. HJR is going to be another one. So we want to check what the upper rib cage is doing and then what the posterior tissues in the shoulder are doing. So looking at the axis of rotation of the joint, if they're getting a pinch kind of anteriorly or superiorly as they're going into flexion, what's not lengthening at the back that's causing that to happen? Again, shoulder capsule, long-headed triceps, they're going to be some of the tissues that I'm really, really interested in. Obviously then I'm going to have to use the assessment to figure out which ones are relevant to that patient, and then my exercises are going to be driving load towards those tissues. So rather than focusing particularly on these are the exercises I use for shoulder impingement, it's okay, what's not doing its job, whether it's upper rib cage, posterior shoulder or whatever, what's not working 100% efficiently that's leading to that symptom of impingement in the first place, and a lot of my rehab exercises are going to be based towards that. And last question so far is, how do you modify the system for older clients? So obviously you've probably heard Dave talking about the system that he uses, that we use here in the clinic and he uses in professional sport. And how would you modify that for older clients? So first of all, on that point, in the clinic here, we treat a lot of older clients here and we use the same system that Dave uses in professional sport. So the system itself stays the same. What we might modify obviously is the loads that we're using, the exercises we're using, etc. But the thought process and the system still stays the same. Obviously, if we might just be using slightly different exercises depending on what that person wants to do. The big thing is we need to get a real clear vision of what the ideal outcome is for that patient. So when is their symptoms coming on? What are they really struggling with? What do they want to get back to doing? And a lot of the graded exposure needs to be geared towards that. So I suppose, and this isn't just for older patients, this is for any patient that walks through the door. Obviously professional sport is always going to be to get back on the field. But when it gets to the private practice, it's okay, what's the ideal outcome here and what graded exposure steps do we need to take to get there? So the system stays the same, but obviously exercises and the levels of load and speed variables, etc. that you use might be slightly different. So I suppose that's the only modification that's made for older patients, and obviously anybody else that you need to make modifications for as well.